Hi, my name is Sawalla Guseh, and I'm one of the MGH Cardiology Fellows. And in this feature of Two Things, we're going to talk about the debut of a new test, the high-sensitivity troponin assay. We're here in the clinical labs of the MGH, and I'm joined by two experts. To my left, Dr. Lewandrowski from the Department of Pathology, and to my right, Dr. Januzzi from the Medicine Department's Division of Cardiology. And so I'll start with you, Dr. Lewandrowski. So a new test is coming out, the high-sensitivity troponin assay. How does it differ from the conventional troponin T that we currently use and know and love?
Well, the major difference between the current test and the new high-sensitivity assay is the analytical sensitivity of the test. We can measure troponin at much lower levels. Our current fourth-generation TNT has a lower limit of detection of 0.01 nanograms per mil, whereas the new assay has a lower limit of detection of 0.003 nanograms per mil. To avoid reporting the test with multiple decimal points, we decided to report as whole numbers, as nanograms per liter as opposed to nanograms per mil. So at first pass, the numbers will look big, much bigger than what you're used to, but in actuality, they're not detecting troponin at a much lower level. The new cutoff is going to be gender specific, in contrast to the one-size-fits-all that we have now. For women, it's 0 to 9, we will flag values that are 10 or greater, and for men, it's 0 to 14, and we'll flag values that are 50 or greater. We're also going to be incorporating delta troponin into our interpretive guidelines, which Jim will talk about later. The new high-sensitivity assay will allow us to detect and rule out acute coronary syndrome much faster than with the previous assay, perhaps in as little as 3 hours following the onset of chest pain. The only downside is when you detect such low levels of troponin, there will have to be a fair number of patients who are going to have measurable levels of troponin in the absence of acute coronary syndrome.
Phenomenal. And so I'll ask you, Dr. Januzzi, as a clinician, what are some of the major differences that we're going to see when clinicians use this test?
Sure. So it's important to emphasize that with the highly sensitive troponin, there's a lot of data already in existence about how to use them. The Europeans have been using this test for almost 8 years now. So the good news is we have a good sense of how they will behave and how to use them. A few important points. One, as Dr. Lewandrowski said, the number that you'll see in the report is considerably larger than what people are used to when looking at troponin values. That should not cause discomfort. It's essentially 1,000 times larger than the current reporting range. So it's important to remember that when you start seeing these results. With highly sensitive assays, the tests are most often abnormal at first blood draw, so they are more sensitive and more rapid for the detection of myocardial injury. But the problem is that because there are many medical conditions that can cause elevated troponins in the absence of a myocardial infarction, you really need to look for the delta, the change. And so they are more sensitive and hence more likely to be elevated at presentation. They rise very quickly in the presence of a myocardial infarction and detect more myocardial infarctions than if we were using even an older troponin or CK-MB. So I tell people, get used to thinking about serial blood draws, stop measuring CK-MB, and very importantly, learn to be comfortable with the recognition that troponins may be abnormal in situations other than myocardial infarction. Heart failure is a great example. Most patients will be abnormal, but they won't be rising with the speed that we see in patients with myocardial infarction.
So this is Two Things, and that was about the high sensitivity troponin. Thanks for joining me.